No rush.
Yeah, so I will do a midline laparotomy, examination of the all the 4 quadrants, and
What does that mean? Examination of the 4 quadrants.
I will look into all the 4 quadrants, looking at the liver, the bowels, and the pelvic organs.
Yeah, it's just exploratory laparotomy in a way. Those buzzwords, exploratory laparotomy, means you will do all those things. So exploratory laparotomy is when you go into an abdomen which is unknown, you always palpate the liver, both lobes, check the stomach. Yeah? You always have to have a system when you do an exploratory laparotomy. I was telling Dr. Chochi this. When you go into an abdomen, it doesn't matter what it is, you always put your hand up to the liver, feel the liver, both lobes, examine the stomach, examine the colon, run the small bowel from DJ to TI. For females, you always go into the pelvis, check the pelvic organs. When you're writing your op notes, you pretty much follow what you do in your operative findings. Liver, normal. Gallbladder, normal. Stomach, normal. Small bowel, no abnormality. Colon, from cecum right down to rectum, no abnormality palpated. So that's pretty much how you do exploratory laparotomy. Okay? So when you're answering an exam, you don't do all that in detail. You say, I do an exploratory laparotomy, looking for any abnormality. Good, carry on, Roy.
Okay. So I'll do a midline laparotomy and an exploration.
Exploratory, I'll do an exploratory laparotomy. When you do an exploratory laparotomy, it's pretty much a midline, right? Don't worry about I'll do a midline. Okay. I'm doing an exploratory laparotomy, means you're doing from xiphistenium to pubic symphysis. Just go towards the key point in this case, right? The key thing is I want you guys to tell me what you would do in terms because of the primary pathology and why. And Dr. Chochi will tell you more about it. What would you do? Would you join stoma, and why?
Yeah, so I would do a exploratory laparotomy, and with the finding of cecal or appendicular mass, I will do a right hemicolectomy, and I will pull out a stoma. Pull out.
So you'll resect and pull out.
Yes, I'll resect and pull out a stoma. And
so what resection?
A right hemicolectomy. And
yeah, that's right, Sanjit.
Yeah, and so I will close the abdomen and
why not join, bro?
Oh.
Dr. Sanjit, don't be shy, or just say what's in your mind. What I want you to just talk freely, and when you're talking, what I want you to say, to think of why you choose that option. There's no option is wrong, and don't be scared to say what you want to say. That's what I want you to do. Be confident to say, I would do a right hemicolectomy and I will bring out an end ileostomy because of this, this, and this. That's what I want you to say. That's what I'm keeping quiet. I want you to speak freely. Don't be shy.
Okay, so I will pull out a stoma. The reason being
An end ileostomy.
an end ileostomy. Reason being, I am suspecting it could be a malignancy, and I would want to wait for the histology and look at my resection margins, whether it's clear or not. And if it is if it involves the margins, and if it is a malignancy, then I would plan for a resection, resection, and a definite procedure with of reversing the ileostomy with that resection. So the key things that I would be looking in the histology is the resection margin, the involvement of or the number of nodes harvested, and presence of or absence of lymphovascular invasion. Probably these are the three things I would be looking for in the histology.
Okay, Chochi or Sela, yeah, Chochi, I guess go for it, right? Just help Dr. Sanjit with his.
I think Sanjit is saying the right thing. Is just exploratory laparotomy. Then you identify your pathology. So you do I'll do my right hemi. Then I'll put an ileostomy, wash the abdomen, and come out and close. So that's just simple. That what can you explain, Jit? You're telling you are on the right track.
You're on the right track, Unoy. That's exactly what Dr. Chochi is saying. That's what I want you to. You pretty much have to just say the big words. Right hemicolectomy, bring out an end ileostomy, wash out the abdomen, I would close. It's we always overthink. We all do that. We overthink what we want to say. But in the exam, you just have 2 or 3 minutes to say that. Right hemicolectomy, bring out an end ileostomy, wash out the abdomen, close your fascia. It's just those buzzwords that you wanna do. And I think for you guys, the more you do this, the better. You know, you do a lot of Zoom sessions. I can just sit at the back and listen to what you guys do. You need to talk more. Just talk. Yeah. I know you do this operation with your eyes closed, but what you need to practice is your just saying it. See what Church is saying? That's pretty much your answer in the exam, those words. And then the examiner might say, tell me how do you do your right hemi? Then you can go into details about how you do your right hemi. Yeah. The keys to the key points. Yeah, I always say the buzzwords. I'm listening to your buzzwords. You just have to tell me, I'm going to do a right hemicolectomy. I'm going to bring out an end ileostomy. You know, we did an Abkarian stoma, which is, that's, you don't have to use that word. It just basically means a mucus fistula of the transverse colon. We brought it out. Okay? And we did that because of, Dr. Chochi will talk more about that. Why, Chochi?
Yeah. It's not it's not a straightforward for this lady. It's not a
Mm.
straightforward laparotomy where you see like pus everywhere and bowels is easy to locate and the momentum. This is already been 1 month, and already during the operation, our mind has already been planned on what to do because of the CT findings and the discussions. So we had a plan in our mind before we go in, which is appendix, remove the appendix, put the drain, wash, come out. Because and it's this COVID time too is difficult. So we go in. The momentum, the small bowel, this lady was also having mechanical obstruction. If you can see in the CT scan, all the small bowel is all down there in the RIF region. So she was having mechanical obstruction, and it's really difficult. It's really difficult. So it's good Dr. Law came in. I was really happy that he was there, and Dr. Dasau. So we released all the bowels, and so the plan was just resection, do resection, the base of appendix, not resection. Initially, it was appendectomy, drain, come out. So as we look at the, I can't feel anything. When I was palpating, there was no nodes, there was no mental caking. We couldn't feel any mess in the cecum because it was been there for like inside the cecum. So, but it doesn't look good. It doesn't look good. So I was thinking if you're going to do appendectomy, maybe it can burst. So the option intra-op. So we changed the decision over with Dr. Delasau, consult with Dr. Delasau is me and Law to continue with the right hemi. So we did we want to do a limited right hemi for this patient. So and also while doing the right hemi, mobilizing the ascending colon, it was all fixed to the gyrotophasia. It's really difficult. But Dr. Law managed to release it from the gyrotophasia, and we mobilized it into the hepatic fracture. Managed to do the resection up at the transverse colon. This changed after we ligate the vessels. So we increased our incision, extended our incision. We were just planning with Dr. Law to, I was hoping to, my plan was to anastomose. So we decided, we have a discussion with Dr. Law to anastomose. Then Dr. Delasau came in. So he just refreshed us about damage control surgery. And then it clicked in the mind again. So at that time of the day, the long of duration, the period, the COVID crisis that we went. So everything, the damage control surgery. So if you resect anastomose, you will be thinking, and people, because of the things, because of the COVID period, it's difficult to go and see patients. Even for us, the registrars want to stay in that ward, you can follow up your patients. So it's really difficult. So I was really happy with Dr. Delasau's decision to just to pull out the stoma and the end stoma with a mycofistula. So that's what we did, but it's not some operation. It's really easy. That one of that one is really difficult, but good that we have hands Law and Dr. Delasau came to help on that day. And also just to answer for JIT, I think that we were answering. That's how I was answering before, and when I was in year 3. So we had a lot of session with Dr. Delasau, and just to come up with some big words. So that's what we've learned. So the more we practice, sometimes we think we have to explain in details, but we just give them the big words, and hide your facts on the back, because they'll ask you those things. So those are some of the tricks that Dr. Ndela Sau teaches us, just to give the big words and keep rephrasing, talk about it so they can ask you that questions. So yeah, thank you. But if anyone of the team can correct me, if they want to, if they can, they think that we should do other way, bring the forum to discuss this kind of case. We all learning from it. Pinaka team.
Yeah.
Boss, so when you ask, like as an examiner, if you ask me what are you going to do, you're basically asking me what are the principal steps that I will be doing.
Yes.
Pretty much, pretty much exactly that. Yes.
Okay.
Yeah. Every time you get asked a question, remember in the exam you don't have time. Yeah, you don't have time to discuss in details. Yeah. The examiner wants to know you are safe, surgeon. You are safe. Yeah, that's a key thing. Like that the diverticulitis talk. No one will do a primary anastomosis, but that's an extra point. Bonus point is like there's options there, but you always do a Hartmann's for a perforated diverticular disease. Very similar to this case, the Dr. Chochi's case. This is a perforated appendix mass. And you rightly say, highlights the points. When I give you the case, every case is given to you, there's always some pointers there. It's a 61 female, 1 month history, COVID. We're in the COVID. She's also COVID positive. These are all your money. These are money in the bank or money for jam. You have to listen in an oral exam, listen for those points. They're telling you something. In a written exam, underline those things. 61, female, perforated or 1 month history of being sick. CT showing appendix mass. All those things, you have experience. You all have experience. When you have an exam like that, cancer, 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 cancer. This is cancer until proven otherwise. So you're already thinking about that. My plan here is to be, safety first and kick for touch. It's not going to be a primary anastomosis. I would do a resection, which is a right hemicolectomy, and I would form an end ileostomy. Why would you do that? The patient is 61. My concern here is cancer. Say that. Don't say it could be inflammatory, it could be this. No. Say it. 61, Fijian female, 1 month history. It's cancer until proven otherwise. So my approach here is right hemicolectomy and ileostomy, mucus fistula of my proximal colon. Boom, stop there. No one will question you after that. So why would you do that? You can say, well, this lady is deconditioned. She's been sick for 1 month. She has peritonitis, and she's also positive for COVID. I won't anastomose her. I would do the safety first, give her an end ileostomy, mucus fistula, optimize her further, and I will do a completion colonoscopy. So I would colonoscope her before I plan to do a reversal. You following me, right?
Yes.
Yeah, those are the words that I want you to use. Just words, one word, boom, 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 boom. And that only will come with practice. So I want you guys, while you're doing these sessions, do this a lot with each other. Get Chochi, get Sela, get Sads. You have to bring these guys in, get Law. You all have to do this together as often as you can. Get Dr. Sela in as much as possible. You have to get Dr. Sela to speak. Before he goes to Australia, it's very important that he speaks. He has to speak. He has to practice talking. He teaches you, and you guys ask him questions. Okay.
Same boss.
This is the best time.
Alright.
This is the best time, anyway. While we having this period, this is the best time to have all these Zooms. I want Sanjit, Pranit, organize a lot of this, not just with the guys overseas, but just between us. I'm very happy to be involved. You guys organize it, get a case together, 1 or 2 or 3 cases every evening, or every, as often as you can. The key to this is talk. Just talk. None of us are born talk, speakers. We only get better if we practice.
Noted, boss.
Anyway,
True, boss.
don't be scared. Never be shy or scared. Look at how Chochi is talking. Chochi has got that personality. Is cheeky. He's not shy to say something, if it's right or wrong. That's the way I want you guys to do it. Don't be scared. We are not English speakers. English is not our first language. So the European will understand if we have a broken English, because it's not our first language. But it's important to say it. Say, I'm sorry that it may not come across correctly, but this is the way I see it. Boom, 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 boom. And that only will come with confidence. Yeah. And don't be scared. Never be scared to say something, because you guys have got so much experience. You have neurosurgery, orthopedics, specials. Don't take that. Don't lose that. You
Yeah,
have
sure.
so much experience, guys.
Don't.
Yeah.
Yeah.
And I want you guys to see those any case you find interesting. It's a good discussion. Put it up and do a Zoom. Let me know. I'll just I'll just be there too. But I just want to encourage you guys to speak more. Speak. Just before we finish, sorry to interfere with your thing. See that histology. I was just asking Dr. Chochi. Dr. Chochi has been doing a lot of general surgery despite his ENT interest. The histology is interesting, yeah, because the first pathology report, Dr. Pranit.
Yes.
Have you had a chance to look at the histology report?
Yes, I did already.
Okay, just tell us what are the main pertinent points in the histology report?
So the pertinent point in this histology report is the tumor size. It's 20 mm. The histological grade is grade 2, and then the extranodal extension to 9 nodes metastases.
Anything else, bro?
Yes.
Go.
What is the pathology? You haven't said. What is the
Right.
diagnosis?
Sorry, the pathology is a moderately differentiated adenocarcinoma, and
Margin.
this ileum, cecum, and ascending column.
Margin?
Where's that report?
I put it up on the Reg, on the Dr. Delso and Reg's thing, Bosho.
Because it says the ileum and the colon resection margins are clear of any tumor cells. So whatever the resection where they resected was clear of tumor cells. And I have the report here in front of me. That's what I'm reading.
You said lymphovascular as well, bro.
Yes, there's lymphovascular invasion seen.
There's invasion through the serosal layer. That's one thing. The margins are clear of any tumors, but it doesn't say how many centimeters. Metastatic in the serosal area. There's transmural infiltration of the tumor cells, lymphovascular invasion, nodes involved, which is 9 metastatic disease, and extranodal extension.
Dr. Saj, Dr. Sella. Dr. Churchy might jump in.
Question again?
The report. Look at the report. That's why you should read.
Okay, so
Is that what's,
Baso, the
what's
thing
important
here
the
is
name?
it shows appendix extension.
So boss is asking what is the pertinent findings on that histology report, Sarah? I think fellows operating.
Saj?
I think the last time I saw it was there's clear margins. It's a grade 2, but there's lymphovascular invasion. That's what I got from it. So no
Yes.
note.
Yeah, I agree with what you guys are looking for. I think if you look at the hey, somebody's phone, sorry. So when you look at the histology, especially for cancer, so we can because it's a pathological grading. So the main things you look for, what's the diagnosis or adenocarcinoma. Then you look at your T and M. So the tumor factors, tumor size. Where is it? Is it T1, 2, 3, 4? Is it perforated or not? Because those things will determine your further management. And then you look at the N, which is the nodal, and then your margins and things which comes in the T. So looking at that histology report, what we can say is she's got a stage 3 disease. Hopefully the CT is negative and intra-op staging was negative, then she's got a stage 3. So ideally, with just that histology, you would say that she needs further treatment in terms of chemotherapy. But again, you're going to assess the need for chemotherapy in terms of, like, you look at the patient and then you look at the institution as well. So patient factors is she fit for chemotherapy? Does she want chemotherapy? What is her ECOG status? How is she clinically? How's her renal function? Because you don't want to give chemo and then deteriorate her renal function if she's on dialysis or renal failure and all those things. So clinically you're gonna assess and then decide for chemotherapy on this patient.
Dr. Sella?
Yeah, no, from that histology, I agree with Dr. Sajani. I would give chemotherapy.
What are the important points there that would what are you looking for? What are you looking for in your histology report?
So, as I think Pernit and Sajil already alluded to the name of the type of cancer, what actual cancer it is, the margins involved, the lymphovascular invasion, the nodal involvement, and obviously the staging preoperatively and the histological staging. So all this will enable me or guide me to my decision whether have further treatment, chemo or not.
Dr. Chochi? Dr. Chochi still there?
Yeah, Bunai.
You're listening to
I was
What- what's
cooking.
what's cooking? What's
Sausage.
what's the pertinent point in the histology report? So highlight the important points. And Dr. Anna, after you, Dr. Anna will have a chance to speak.
Yeah, so so all the reports, what we expected is lymphovascular invasion, like the TNM staging. So you, all the report, you should make sure that you have the TNM staging.
Yes.
What's the TNM, right? So that's exactly what I'm trying to the guys to say. What's the TNM stands for? What's TNM? What is it?
Tumor,
The-
nodal, and metastasis.
Yeah, the tumor size, like the areas of or the invasion, the degree of invasion, and N is nodes, M is mets.
Yes. Good. Make it keep it simple, guys. Keep it simple. I think you're jumping in too much into lymphovascular invasion, all this bullshit. Go back to the basic, eh? So your S-local classification, and which one you use, your TNM or the other, but stick to TNM or the staging, or the grades. What do you call the stages? Stage 1, 2, what do you call A, B, and C? So I'll stick to TNM. Stick to TNM. That's simple. TNM, and all the organs. It's important just have all the organs have a simplified way to describe the staging of every cancer in all the common organs: colon, rectum, esophagus, liver, gallbladder. They all have their TNM classification of their cancer. So just have that summarized somewhere, because there's always be a question of the tumor staging or tumor grading. So that's why in a report, in a pathology report or histology report, that's what the pathology is trying to give you, is that TNM classification or S-local classification grades. So that's what you look at. So tumor, they'll describe in the macroscopic. There's a macroscopic and there's a microscopic. So macroscopic is basically what they see with the naked eye, as you know. Microscopic is the microscopic view. The microscopic view classify all those things, what they see under the microscopy. That's where the TNM comes in. You get T1, T2, T3, T4, N1, N2, N3, M0, M1, M2 in most cancers. That's why you need to keep it simple. For all your organ cancers, just have the TNM for each of them. And they will give you a histology report like this. They'll be like, tell us what are the pertinent findings here. And the questions will stem from that. What are the pertinent findings and what's your management plan based on these findings? That's what I'm trying you guys to drive at. So every case you do, always follow up your histology and make a plan based on the histology. If something is not clear, then you look it up. And what I've been trying to do is get you guys to get a prognostic calculator. Just have anything, Memorial Sloan Kettering, American Cancer Guideline, anything. Have it on your smartphone. So every cancer you get, you enter all those details from your pathology report. And that will give you a prognostic indicator, the survival after 5 years, after 10 years, plus or minus chemo. If we give chemo, what benefit will they get? That's what you guys need to be going towards as a surgeon. Is not just doing the surgery, it's the staging of the cancer and the follow-up after. You have to decide chemo or not. If chemo, what benefit? The patient is going to ask, how much more time will I get if I get chemo? Because a lot of the times we say chemo, no chemo. The benefit is based on those approximator or calculator, prognostic indicator. So in that histology report, the key factors there is the tumor size. It's a 20 centimeter cancer. It's perforated. Again, that's a big factor. It's perforated. So that's pretty much T4. N, nodal involvement. It's 9 out of 11 nodes positive. M is M naught. I'm not sure because I think there's omental deposits.
No,
So
no omen.
Yes.
No momentum. So it's M naught. So it's a
M.
T4, N, N2, N3. Doesn't matter. But just again, the principle is key. So it's already got 9 out of 11 nodes. And then M naught. So T4, N2 or N3, M naught. That's pretty much that's the answer I'm looking for. So you guys to give me that TNM based on that report. So when you get given a pathological report, have that in your mind. I'm looking for the tumor size. I'm looking for the nodes. I'm looking for the METs is obviously from your workup pre-op, your CT staging, MRI, all your workup, and also your intra-op findings. That's why I'm always saying your exploratory laparotomy, you always feel for the liver, run the small bowel, check the rest of the colon, feel for omental caking, because that's part of your M staging, metastatic M. So when you're deciding chemo or not, it's based on that. And then again, is chemo gonna benefit them or not? As Dr. Saj is saying, ECOG, patients like it or not, and how much benefit are they gonna get? 1, 2, 3 years, So that percentage of, so this lady, when I got the first report, I put it through the MSKCC calculator. It was like a 5-year survival was 50 something percent, 54, 57%, 54, Yeah. So you've got that, there's the surgery has done some good. That's even without chemo. She has a 50% 5-year survival.
Sorry, boss, which calculator was it?
MSKCC, Memorial Sloan Kettering Cancer Center, MSKCC. There's also the American one. There's a few other things there. Just have something on your calculator. So every time you have a cancer, it's all like stomach, esophagus, liver, gallbladder, colon, rectum. You just enter their age, all those things. Yeah, size of the tumor, lymph nodes, Mets. There's a thing that you just enter in and gives you the 5-year survival, 10-year survival, and some of them have the chemo as well, with chemo, without chemo. So when you're talking to your patients, you just give them that. Certainly.
So it's that form score, forms.
Pardon?
The score, it's form score.
Form.
It says that form score was developed at Memorial Sloan Kettering Cancer Center.
Just type in MSKCC prognostic calculator or prognostic indicator.
Typed it's giving for RCC, renal cell carcinoma.
There should be options of all other cancers there.
Okay.
When you choose the type of cancer. You can download, you can download an app. There's an app. If you have space in your phone, download an app which can give you this sort of quick. It's just a guide. It's a guide that when the patients ask, you can always give them. 100 patients in your situation, 50 will be alive. Within 5 years. Because of this, and this, It's just a number that you have to simplify it for them.
Yeah.
Certainly.
Yep.
Any other thing, Dr. Chochi? Any other pointers for this case?
No, right.
That's pretty much it.
Yeah, I think it's a good thing to prepare the team for exam. I think also refreshing us because people doing general and goes to other specialty. Good
Yes.
time to learn other general. We have to make sure that we learn our general again. I think it's a good class today. Thanks, everyone. Thanks, Funwai.
Naka.
Chochi, you drinking grog?
No, man. I'm just feed cooking.
Oh, what are you cooking? Sausage?
Bless you.
Oh, pie.
We are talking here constructive here for the Anna's benefit, and you want to disturb.
It's
Like
Dr.
the class
Anna and Dr. Sonam. Anna and Sonam. Anna?
Hi, Bunway.